Hello, I'm Dr. Paul Cross. I'm a consultant cellular pathologist based at the Queen Elizabeth Hospital, Gateshead in the United Kingdom. And I'm going to speak today about cervical cancer screening. I have a long history of working in the cervical cancer screening program in the UK and involvement with screening programs elsewhere in Europe and further afield. What I'll be speaking about is, the talk outline is what is screening, what is the natural history of cervical cancer, options for screening, vaccination, treatment, and what is the possible future direction. Well, no talk about cervical screening would be allowed without mention of George Papanicolaou very early on. George Papanicolaou, who everybody I'm sure will have heard of, who's involved in histopathology, cytopathology, or cancer screening, helped devise and develop the Papanicolaou smear, known as the Pap smear generally, through his work on the estrous cycle of the guinea pig in the early to mid 1940s. It's that led him to look at samples further afield and from humans, which led him to detect abnormal cytological changes, which then led him to understand that changes could be identified cytologically, which correlated and equated to cervical precancer and cancer. And the Papanicolaou smear there on the right hand side is the classic sample that I'm sure will be well known to many cytopathologists. Before we begin screening, we should understand the principles of screening and what are the important aspects that should be considered. Wilson and Younger's principles of screening, going back from 1968, cover the main points. There are versions of these edicts or principles that have been expanded upon subsequently, but the basic ones are here. It should be a condition that is identified as an important health issue. We've got to understand the natural history and understand how it develops and what we can do about it. There should be a recognizable latent or early pre-symptomatic stage potentially, which allows early treatment, which may actually prevent a cancer. So we may not be detecting cancer per se, but are looking to detect pre-cancer before it has actually developed into an invasive lesion. Whatever the test is we're going to use has to be suitably devised and allows it to be done. It must be acceptable to the population, and there's got to be an agreed algorithm on what to do if the test is positive and what should be done about it. You've got to offer diagnosis and treatment, otherwise there is no point in screening. And of course, it's got to be affordable to the health service offering it and the nation offering it. And there needs to be a continuous process. It is invariably not a one-off event, although I'll come onto that perhaps later. So if we look at population screening in general terms, we are looking at what is perceived to be a healthy population in general terms to identify the one or two individuals that may have a positive test which may predict their susceptibility to develop a cancer in this context. These individuals invariably feel well and do not feel unwell. So we may be making people arguably feel have disease who were not feeling so before the test was done. And we must therefore ensure that the false positive and false negative rates of the test are low, so that we do not make a worried population when only one or two of them may actually have the disease. An organised cervical screening programme will have all these components. However, the degree to which each of these is present varies very much on the screening program that is being offered, the facilities that are there to offer that service, and the natural history of the disease in your population. In my own country, we have all this in place, but then we have a screening program which has been around for 40, 50 years. However, if you're at an early stage of development of a cervical cancer screening program, you may not require every aspect of this. And that very much depends on where you start from. And as I say, the instance of disease in your population. But again, I'll come back onto the aspects of that later. So if we're looking at cervical cancer and its natural history, well, I think all of us will know that human papillomavirus, HPV, the infection with this virus is a key event. There are numerous cofactors, which again are identified as number of sexual partners, age of first intercourse, immunosuppression in any way, shape or form, and smoking are all predisposing factors which allow the development of the HPV virus into potentially precancer and cancer. In the vast majority of women who are infected with HPV, this is a transient asymptomatic condition and resolves in the vast majority of cases. However, in a low percentage, 10 to 20%, the HPV infection may persist, and in a proportion of those, it may persist and progress to invasive cancer. And this will only occur if the HPV DNA becomes integrated into the host cell DNA, therefore diverting the cell from its natural history. So the vast majority of women with HPV infection will be asymptomatic and will have no problem. It is the minority who can progress, and that is where screening should be targeted against. Look at the HPV virus itself. It's a double-stranded DNA, over 100 subtypes known, and increase fairly regularly. The virus itself has a predisposition to attack the basal layer of squamous epithelium, and that accounts why the HPV virus as a general virus causes many conditions, including cutaneous viral warts. However, there are numerous types associated with cancer, and this leads us into the concept of low risk and high risk HPV subtypes. Of the 100 subtypes, certain ones are associated with a predisposition to developing precancer and cancer. These are the high risk subtypes. The virus, if it integrates, it's the activity of the E6 and E7 proteins, which inactivate two tumor suppressor genes within the cell, the P53 and the proretinoblastoma genes. And it is this alteration of the normal genomic function of the cell that allows it to develop into a precancer and potentially cancer. But as I've indicated, this infection may be transient. If we look on this graph here, the purple line represents HPV infection, and the vast majority of these occurs around first intercourse or during first sexual exposure, and the vast majority it wanes off and is an asymptomatic, if not fully expelled virus. However, in a proportion, it will persist and potentially integrate, and with time that can lead to a cancer, the green line. However, there is a definite lag period between infection, precancer and cancer. And the development of cancer from the origins of precancer can be typically 5 to 10 years. So there is a window of opportunity which allows a screening program to detect virus presence and potentially the precancerous phase before it is developed into a true invasive cancer. If we look at the high-risk subtypes, there are numerous ones identified from the literature and from HPV analysis of cervical cancer and precancer. However, the two big HPV subtypes associated with 70–75% of cervical cancer are HPV 16 and 18, and we'll come back to the significance of this later. However, it must also be identified and pointed out that the vast majority of anogenital squamous cancers, as well as some adenocarcinomas, are also associated with the same HPV subtypes. So not only is cervical cancer associated, but also vaginal, vulval, anal, and also other HPV-driven squamous cancers, such as oropharyngeal squamous carcinoma. The low-risk subtypes, and here I've identified HPV 6 and 11 as two examples, are not associated with a high risk of precancer and cancer, but may be associated with other manifestations of virus infection, such as anogenital warts. If we look at the stage of cervical cancer, this is cancer data from the England over the last few years. Data is a bit old, but it's still typically the same. The idea of screening is to identify early stage cancer. So in the UK program, more than 50% of cervical cancers identified are via screening or at very early presentation, stage 1. The vast majority are treatable and with minimal, if no recurrence or spread. However, there are obviously higher stage diseases which can occur. And arguably, these are not going to be identified through screening per se, but will invariably arise and present symptomatically. However, I'm fully aware that in other parts of the world, this table would be turned around and the vast majority of cases would be stage 4 with very few at stage 1. So it very much depends on the incidence of the disease in your population and what has been developed and has been used to identify and treat those precancers and cancers in the past. However, we must remember that cervical cancer, as defined by WHO, is a highly preventable cancer, and access to prevention, screening and treatment, the lack of access to that contributes to 90% of deaths. And certainly, if coverage, vaccination and screening were better organized in the vast majority of the world, the vast majority of women who suffer death from cervical cancer would not do so. It is a highly preventable cancer. If we look at incidence rates of cervical cancer around the world, it varies enormously. And as you can see here, there are certain hotspots in sub-Saharan Africa, parts of Russia and the Far East, and South America. Many of the countries where there's been an organized program over many years has helped reduce, if not largely eradicate the disease, although no country would claim full eradication. If we look at the incidence, the crude incidence of cervical cancer, going again back a few years, but we see a lot of East European and African, South American countries. Those countries with more organized programs, such as the UK, America, are down at the lower end of the spectrum for incidence. Some countries, possibly due to social and religious beliefs, have a lower incidence for that reason. The incidence also of HPV subtypes does vary enormously around the world, but still HPV 16 and 18 are the two critical HPV subtypes associated with the vast majority of cervical cancers worldwide. If we look at guidelines about cervical cancer screening, the World Health Organization has produced a whole plethora of documentation and guidance, and all available on their website. However, there are several documents which I think are worth highlighting and which I will draw from for the rest of this talk. One is the Global Strategy Towards Elimination, which is from 2019, recommendations on screening and treatment, women living with HIV, and also guidance on cervical precancer and treatment thereof. Many of these documentations are several hundred pages in thickness with a good evidence base and guidance. They're very practical documentation, but certainly lays out the strategy for global eradication. And the World Health Organization 2030 Global Strategy is towards elimination of cervical cancer. And it's often referred to as the 90-70-90 guidance. In essence, what they are advocating is that 90% of girls are fully vaccinated with HPV vaccine by age 15. Again, I'll come back to that later in the talk, but the logic being that if you are immunized against HPV subtype infection, you would not be able to have an HPV infection and hence should not be able to develop HPV-driven cervical cancer. The 70% refers to a screening test of high performance by age 35 and again by age 45, i.e. at least 2 screening tests in the early reproductive life cycle of the woman, which may identify those cancers that have developed either because non-HPV driven or where the HPV vaccine may not have been as effective. And 90% of women identified are treated either at a precancerous stage or invasive cancer. It is estimated that if the 90-70-90 targets were achieved by 2030, then by 2120, over 62 million women would not have died of cervical cancer who might have otherwise done so. That is an enormous figure. And it's obviously a very worthy goal. And given that HPV is the driving force behind cervical cancer, is eminently achievable. There is, of course, a significant cofactor, particularly in sub-Saharan Africa, where HIV does increase the risk 6-fold of developing cervical cancer compared to women without HIV. Obviously, HIV is an immunosuppressant infection in its own right, and it is estimated that 5% of all cervical cancers are attributable to HIV, but that can vary enormously depending on the local HIV prevalence. So again, surveillance in the HIV positive female population would have to be more than likely at a more frequent interval, given the immunosuppressive character of HIV infection itself. So if we go back to the WHO guidance, there are 3 main preventative strategies. Primary prevention would be HPV vaccination, i.e. try and prevent HPV infection at all, and therefore hopefully not develop cervical cancer and precancer. That would be offered to women, girls, but also to boys. And that would be coupled with health education in general and around barrier forms of contraceptive to help reduce the risk of HPV infection and transmission. Secondary prevention would be active screening of the population at whatever interval and age groups can be organised. Obviously, that must be a high performance test, which must be able to detect significant HPV infection or precancer. It's also got to offer immediate treatment and diagnosis. Otherwise, you may not be able to actually act on the result, particularly if you have a transient population or a mobile population who may not represent for treatment. And obviously, tertiary prevention is those women with cancer where they must be offered the full range of appropriate treatment modalities. And that obviously covers surgery, radiotherapy, chemotherapy, and palliative care. And that is expensive. But the upshot is that if all three planks are implemented, the incidence of cervical cancer would be dramatically reduced. And hence those women requiring more radical treatment would also be radically reduced. So what are the approaches to cervical cancer screening that the World Health Organization advocates? Again, three main planks: molecular, cytologic, and visual inspection. And if I start with visual inspection on the right-hand side first, this is probably the lowest technological approach, but very effective. And this is literally visual inspection of the cervix with Lugol's iodine or acetic acid. So VILI, visual inspection with Lugol's iodine, or VIA, visual inspection with acetic acid. That allows the colposcopist or person inspecting the cervix to identify abnormal areas, and that may require biopsy and diagnosis, or, depending on the circumstances, a primary treatment therein. Cytological approach is using either conventional Papa-Nicolau smear, which I've touched on, or liquid-based cytology, possibly adjunct to HPV testing or other tests. And then nucleic acid amplification, which is the primary HPV DNA, possibly mRNA testing for virus infection, possibly methylation markers, which again is possibly more in the future, and then acting on that. So there are three main planks, and depending on your program, you may have some or all of this actually operating at the same time. So cervical screening isn't a single option for any particular country. The delivery model is very dependent on the resources, incidence, and population. In countries with a high incidence of cervical cancer and little or no previous screening, it may well be more about cancer detection than pre-cancer detection. However, as that program develops and hopefully vaccination is implemented, that will switch over to pre-cancer detection and the number of actual cancers will decline. The idea of all of this must be to identify all cases of cervical cancer at a more early cancer treatable stage or at a precancerous stage. And of course, only screen if you can actually offer treatment. Otherwise, there is no purpose in that screening at all. Again, if we look at the World Health Organization guidance, there are two screening/treatment approaches. The first is the screen and treat approach, where the decision to treat is based on the primary or positive primary screening test only. And again, I'll come on to that in a moment. The screen, triage, and treat is very much where there is a positive primary screening test, followed by a second, either confirmatory or triage test. And that allows the treating physician to decide whether instant or active treatment needs to be done now or can be deferred to surveillance. This invariably requires histological diagnosis. And again, depending on the infrastructure in your own country, is whether that is feasible. Not all countries are able to offer histological diagnosis or histological services. And hence, the screen and treat approach may well be more appropriate in many countries to the screen, triage, and treat approach. If we look at the algorithms, which I'll go into in slightly more detail, again, World Health Organization identifies 7 separate strategies. 2 are along the screen and treat, i.e. a primary positive test followed by immediate treatment, and 5 screen, triage, and treat. Now, all these are legitimate screening approaches, but depend very much, as I've said before, on infrastructure, socioeconomic infrastructure of the country, religious beliefs, and also the incidence of disease. So all of these are perfectly applicable algorithms depending on where you are starting from. However, before I get into more detail on the screening algorithms, just to refresh our memories as to cervical cancer and its origin. If we look at here, the schematic diagram of the female genital tract, here we have the vagina with the uterus, fallopian tube and ovary. If we look at this blown up section here we have the lower end of the uterus with the endocervical canal and the cervical os here and the ectocervix going into the vaginal epithelium. The area of the transformation zone is the area where the squamous epithelium of the ectocervix meets the glandular tissue of the endocervical canal. So we have the squamous epithelium boundary in blue here, endocervical canal glandular tissue in red here, the squamo-columnar junction. The area where the glandular tissue is undergoing transformation to the more robust squamous epithelium is the area of the transformation zone. And it is here that HPV virus tends to integrate, and it's here that is the primary site of cervical precancer and hence cancer development. So any strategy to treat and identify cervical precancer and cancer needs to ideally identify the squamo-columnar junction and the area of the transformation zone. In this schematic, in this histological mega section here we have the ectocervical canal here, cervical os, and the endocervical canal, and you can see the glandular structures. So it is this area here. This also reminds us that 85 to 90% of the carcinomas of the cervix are of squamous cell type. If we're talking carcinoma of the cervix, it is invariably squamous. There is 15% perhaps are adenocarcinomas, and a lower percentage are adenosquamous carcinomas, a mix of the two. But by far and away, the commonest is squamous carcinoma. So if we look at the screening algorithms as identified on the previous slides I've shown you, algorithm 1 is a primary VIA, visual inspection with acetic acid. And this is inspection of the cervix. Here we have a colposcopic digital image of a cervix. Here we have the cervical os. Here we have an area of ectopy or eversion of the glandular tissue of the endocervical canal into the outer aspect of the cervix, so it looks more reddened. But with the application of acetic acid, an area which is more abnormal will show as white. It does not mean that is precancer or cancer. It is just that is an area which may be undergoing transformation to precancer. So if you are doing a visual inspection and you have no option of biopsy, i.e. histology, then you may go for ablative treatment. So that could be purely cryotherapy or laser therapy or heat ablation. If ablation is not possible or histology is able to be offered, then a large loop excision of the cervix, a LETS, can be offered, which allows histological confirmation of the diagnosis. Obviously, if that is precancer versus cancer, the treatment options may be different. It depends again on your infrastructure as to what may be offerable. Obviously, if it's grossly appears to be a cancer, then none of those may be an option, and it may be straight to palliative or chemotherapy, depending, or radiotherapy. So again, just to show a normal cervix here, and after acetic acid, you can see these grayer white areas of aceto-white transformation, which may harbor precancerous changes. On this one, this is a grossly abnormal cervix, which is actually a cervical carcinoma. In this particular instance, the whole area stains with aceto-white, and this is what a cervical cancer would look like. Yes, ideally you would have histological confirmation of that, so you know exactly what you're dealing with. But again, it depends on your infrastructure whether that is feasible. If we look at the other algorithms as we go through, the other screen and treat algorithm is with HPV DNA testing. Now that can be offered at a bedside rapid diagnostic approach, like the Bill and Melinda Gates Foundation have been looking at this for many years, where basically you can do HPV subtyping. And if it was, say, HPV 16 and 18, you may offer treatment based on that alone. Again, it depends if you have the option of histology or not. However, if you then look at the 5 screen, triage and treat approaches, the commonest primary screening test is cytology. And again, that can be coupled with HPV testing. And depending on the combination of cytology, appearance and HPV subtype may be referred for treatment or offered monitoring, depending on the degree of abnormality. Obviously, again, this all depends on your infrastructure. So again, if we're looking at the cervix and the area of the transformation zone, any cytological sample for examination down the microscope, such as the conventional pap smear or a liquid-based cytology, LBC sample, ideally requires sampling from the area of the transformation zone. So again, if we're looking at the cervical os here, this is the area where the sampling device, here a Cervex brush, would be inserted, swept 5 to 6 times, and then either spread on a conventional glass slide for a conventional Papanicolau smear, or cells dispersed into the liquid-based medium and sent for examination and processing. Again, the actual cytology approach depends on what you have available. The vast majority of samples, certainly in Europe, America, and Far East, would be on liquid-based cytology. This is the thin prep. There is also the SurePath cytology mechanism. The theory being that if you disperse the cells in a liquid, they should be evenly distributed. A probe for the thin prep system is immersed. A slight negative pressure is applied, which allows cells to be form a barrier on the end of the probe, which can then be inverted, and that can then be blown out under positive pressure to produce a circle of cells on a glass slide. And this is typical of what you see with a thin prep cytology sample. The advantage of the liquid-based cytology mechanism is that it allows HPV testing and other ancillary testing. It also allows 6 to 8, possibly more, cytological preparations to be made. So further samples can be taken for teaching, education, referral. But it is a robust system. It is, however, very technological dependent and requires an infrastructure for both transport, processing and reporting, again, which may not be available depending on the setting. So down a microscope, and I couldn't possibly leave without doing some cytology. Here we have examples of normal superficial squamous cells and intermediate squamous cells from the ectocervix. And here we have some metaplastic cells with some mild nuclear atypia, but this is more obvious in this example, where we have an intermediate cell here with a small pycnotic, slightly distorted but ovoid nucleus, compared to these highly abnormal, high-grade squamous intraepithelial lesion, HSIL, or high-grade severe dyskaryosis in the BSCC terminology. So what we are looking for with cytological examination is an increase, invariably an increase in the size of the cell, irregular nuclear outlines with this sort of notching, coarse clumped chromatin, and peripheral condensation. The grading of these abnormalities depends on the ratio of the nucleus to the cytoplasm. So what we're looking for is basically variations in size, shape, and staining of cells down the microscope, but it does require a large infrastructure to allow that. So if we move on to other screen, triage and treat, we can do, as I've said before, HPV DNA testing is your primary, and you can triage either on the HPV status, leading to treatment or not, depending, or HPV DNA testing followed by VIA, and then depending on your options for treating, or you can do primary HPV DNA testing, and that is your sole primary screening test, and then colposcopy is your secondary, or HPV DNA testing with cytology triage, and then referral depending. So there are variations on a theme, but they are all involved, well, invariably all involving DNA testing of HPV as the recommended primary screening test. But that requires infrastructure, it requires molecular diagnostic testing equipment, and it also allows time, because to get a result back may be hours after you've taken the sample. And if the lady is not going to wait around for a result, that approach may not be feasible in the field. which is why the Villi-Via approach can be quite attractive, because inspection of the cervix allows instant examination and can allow for a see and treat without an intervening step. If we're looking at all of these HPV DNA type testing in my own laboratory, this is the sort of equipment we have for HPV DNA analysis. A couple of Cobas 680s here for HPV analysis, and any that are HPV positive in my own program are then made into cytology samples. So very technologically dependent, very staff intensive, despite the fact it's automated, because we are getting several thousand samples a day, and that mounts up to a large workload. But again, it is expensive compared to perhaps other ways of offering a program. If we look at examples of transformation of cervical screening, in my own country, we used the conventional Papa Nicolau smear as the primary screening tool from 1988 to 2005. So roughly 27 years of examining a cytology sample alone. We then progressed from around 2005 to cytology screening with a liquid-based cytology, moving away from the Papa Nicolau conventional spread sample. So we use the liquid-based sample, which allows HPV testing as well as cytology. For that 13 years or so, we did primary cytology screening with reflex HPV testing. So cytology was the primary screening tool. HPV that was then done on a positive abnormality, and that allowed us to triage potentially on the basis of HPV status as well as cytology. However, since 2019, we have now moved to primary HPV screening with reflex cytology. So the reverse of this. So we now undertake HPV screening as the primary model of testing, again with a liquid-based cytology sample on a sample taken from the cervical transformation zone area with the cervix brush. And any which are HPV positive for high-risk HPV is then subjected to a reflex cytology. Now, again, that is a labor-intensive program, and there's been a huge transformation in how the screening program has operated. So if we just look at an example of transformation in my own program, my own country's program, around the turn of the century, we were inviting just over 4 million women, and that hasn't changed dramatically. We're still inviting about 4 million women. Our coverage has dropped from sort of low 80s to basically low 70%. So we are not achieving a good population coverage, although there are many reasons for that, and we are attempting to reverse that. However, because we have gone from a cytology first approach to an HPV with reflex cytology approach, the number of cytological samples being examined has gone from 4 million or so, i.e. almost equivalent to the number of women invited, and has declined to somewhere in the order of 500,000 samples. So there's been a huge downturn in the cytological workload because of the move to a primary HPV screening test. Not surprisingly, that has led to a huge reduction in cytology screening labs from the early part of this century at around 140 to around 8. And that makes a huge difference in the infrastructure and the arrangements for that program within the country. Interestingly, the number of colposcopy units for referral for treatment, for diagnosis and treatment beyond the screening has not declined ridiculously compared to the number of laboratories. So transformation is possible even in an established program. In some ways, it may be harder to transform a program that has been established and set up because you are changing old habits for new habits. It is often easier to start afresh with good evidence and start with a good approach. And certainly HPV primary is the ideal approach. And I'll come into why that is a little bit later. However, screening, whilst it is effective, already accepts that HPV virus may well be present. Therefore, to stop HPV infection would be the ideal primary preventative tool, and that gets us to HPV vaccination. HPV vaccination, all the vaccines currently available commercially immunize against HPV 16 and 18, which, as I've said, cause around 70% of cervical cancers. The incidence of HPV 16 and 18 does vary across the world, but typical figures are 70%. The non-valent or 9-valent also protects against 5 additional subtypes, which cause another 20%. So the vaccines currently can cover arguably 90% of cervical cancer. It will not necessarily cover all cancers, either because it may be HPV independent, HPV subtype not involved in the vaccines. Whilst there is cross immunization with other HPV subtypes, it may not be against all subtypes. And obviously the relative importance of subtypes may vary in a good vaccinated population. The vaccines have been proven to be safe and effective and to reduce both precancer and cancer. There is a lot of vaccine hesitancy in the world, particularly in certain countries, and that perhaps has been fueled by the experience in some populations with COVID vaccines. Certain people are just vaccine averse, and it is difficult with the number of vaccinations that are being offered these days to convince everyone that vaccines are safe and effective. However, there is very good evidence that the HPV vaccine is effective. It is most effective, however, if it's given prior to HPV exposure, and hence the recommended age of vaccination in women is around 9 to 14, i.e. young girls who are prior to first sexual intercourse. Obviously, that can vary with population, but ideally, the vaccine is most effective if given before exposure to HPV. Some countries are also vaccinating the males because obviously the male is the transmitter of the HPV vaccine, although seems to suffer far less consequences of that HPV than the woman does. Vaccination does not replace screening, but it will drastically reduce the incidence of cervical cancer. So even in a well-vaccinated population, there will still be some examples of cervical cancer that sadly break through or develop. So screening will not be eradicated by vaccination, but the approach to the approach to screening will be radically different if the vaccination is well implemented. It must also be borne in mind, as I've said before, that any other HPV-driven squamous cell carcinoma or other HPV-driven cancer will be affected by the vaccination. It isn't just cervical. So that will include vulval, vaginal and anal cancers, but also oropharyngeal. So the benefits of the vaccine is more than just cervix. And all the evidence, again, indicates that this is so in a well-populated population. If we just dwell on HPV vaccination for the moment, here we have a HPV virus itself. Most of the vaccines use the L1 protein as the antigenic stimulant, and there are three, although others may develop, general vaccines available: Cervarix, which is the bivalent, Gardasil, the quadrivalent, and the Gardasil 9, the nonavalent. All involve HPV 16 to 18. There will be some cross immunization with other subtypes, but the Gardasil 9 covers the vast majority of the biologically proven and important HPV high-risk subtypes. So Gardasil 9 is most likely the most effective given its broad approach. If you look in the literature, and this is some work from Sweden about HPV vaccination status and the incidence of cervical carcinoma. If we look at this orange line, this is the HPV, the incidence of cervical cancer in an unvaccinated population. If we look at the vaccinated population, those vaccinated over the age of 17, i.e. arguably after first intercourse or before the appearance of first intercourse, is a dramatic reduction. So HPV vaccination can radically reduce cervical cancer by eradicating the precancerous phase. And the age at which the immunization is given is critical to getting good coverage, hopefully, but also good effect. And if we look at this rather busy table, the point I just want to point out is that in the unvaccinated population of which that previous graph was used, 538 examples of cervical cancer as opposed to 19. So vaccination, whilst effective, is never going to be 100%. Not every vaccine takes, not every woman may have the full course of vaccination, and some women may develop an HPV non-driven cervical cancer or other subtypes. So yes, vaccination is effective, but we must be sure that screening is still available. In this paper, which has recently been issued, just to make the point here, in the UK, in England, this conclusion is the main point I want to stress. In England, routine primary HPV screening increased the detection of cervical intraepithelial neoplasia, grade 3 or worse, and cervical cancer by approximately 40 to 30% compared to liquid-based cytology alone, i.e., the use of HPV as a testing platform is very highly effective. So the advantage of HPV testing is if you're HPV negative on the primary HPV test, your chances of having HPV driven precancer or cancer is vanishingly low, and you can effectively be allowed to go back to a secondary screen, maybe 5-10 years interval. What it does mean, though, if you're HPV positive for a high risk subtype, you are at greater risk. However, we do not at the moment, we're not able to identify which of those women will regress or progress. So we tend to have a blunderbuss approach to treatment, so that anybody who is HPV high risk subtype positive will be offered this effectively the same treatment, because we have no way of differentiating those women who may progress rather than regress. And again, just to show how relevant this is an article on the BBC news site from just literally a day ago about how vaccination could mean, in a good vaccinated population, they may only require one cervical screening test, be it smear or other, in their lifetime. And this is the negative predictive value, i.e. a negative HPV test can be so relied upon that your chances of developing cervical cancer is so low that you may not need to be screened for many years. So the negative predictive value is highly advantageous in the screening program. So if we touch on treatment as a continuation of screening, because it's important that if we offer screening, we must be able to offer treatment. Again, the World Health Organization offers technical and clinical advice. Screening ideally would identify pre-invasive cervical cancer, but as I've said before, it does depend on the state of your program, whether it's pre or invasive cervical cancer initially. Obviously, to identify and treat, you must inspect the cervix, and that can be done, as I've said, by VILI or VIA. Ideally, you would have histological diagnosis. That would allow you to know exactly what you're dealing with and offer treatment accordingly. In the absence of a histological diagnosis, again, the only treatment that can be offered is ablative. Excisional can be offered, but if you're not going to examine it histologically, there's very little point in excising, and ablative therapy, therefore, is probably more appropriate. If you're going to offer treatment for a cancer, you need to be able to offer the full workup. That's both clinical and radiological, and then treatment. And that involves decision to treat. Is the woman able to survive and put up with the offered treatment, be it surgical, radiotherapy or chemotherapy? There's got to be symptomatic control, physical, mental support, because this is obviously a trying and testing time for the woman physically and psychologically, but also palliative. And this is why prevention, i.e. vaccination, is far better than treatment in general terms, because it will allow the eradication of the cancer before we even get into any treatment options. So if we're looking at examination of the cervix, we must be able to identify abnormalities of the cervix. And this is where the colposcopist examining the cervix will typically identify 3 types of transformation zone, type 1, 2, and 3. So in inspection of the cervix, if you're going to offer a treatment, you want to be able to see the lesion you are treating, both the lower limit, i.e. the ectocervical or vaginal aspect, but also the upper limit in the canal. So if you can see the whole area of abnormality, which may be in the transformation zone, such as here, you can offer an ablative or an excisional treatment. If the upper limit is difficult to identify in the canal or is unable to be examined, then treatment may be more problematic. And particularly in a type 3, where the upper limit of the lesion cannot be identified, you may well be able to offer treatment to what you can see, but if you cannot eradicate it, then you may well be leaving behind an aspect of cervical cancer, which you may not be able to treat at first treatment, and therefore either will recur or spread. So inspection of the cervix is important, and education and training for the colposcopist is just as important as to the sample taker and to the pathologist or cytopathologist involved, either with HPV analysis or with cytological or biopsy interpretation. As we know that the precancerous stage develops on the squamous epithelium. If this represents normal squamous epithelium here with the basement membrane and the underlying stroma of the cervix, the model that we have is that HPV integration occurs and there is a natural progression potentially from low grade abnormality to higher grade abnormality, and if untreated in a percentage will develop into invasive cancer where there is spread of cancerous cells through the basement membrane and into the body, i.e. invasion, which is the hallmark of a cancer. Depending on where you are and how samples are reported, the cytological equivalents, LSIL and HSIL. LSIL stands for low-grade squamous intraepithelial lesion, HSIL for high-grade squamous intraepithelial lesion. And these can be split into moderate and severe, depending on the degree of abnormality. I won't dwell on the criteria, but these refer to the Bethesda cytological classification, which some of you may well be familiar with, or the British-based BSCC terminology of mild, moderate, and severe dyskaryosis. However, in general terms, these equate a low-grade or LSIL lesion to at least a SIN1 or cervical intraepithelial neoplasia grade 1, moderate HSIL to at least a SIN2, HSIL severe or severe to a SIN3. Dyskaryosis in the British terminology just refers to abnormal nucleus. If we accept that this is the generally held model, what we don't know is which cases will progress. And as I've identified here, 90% of CIN1 cases, the lowest grade cases, will regress if left untreated, whilst only 60% of SIN3, the highest grade abnormality, will regress. Only 40% may progress. However, we cannot tell at the moment which of those will progress or regress. So if we identify SIN3 on a biopsy, we effectively have to offer excisional or ablative treatment, whichever is available, because we cannot at the moment identify which way that will happen, i.e. whether it will regress to normality or progress potentially to a cancer. Obviously, the mainstay of treatment, as I've said, can be ablation, but in those areas where large loop excision of the transformation zone is available, this is the removal of the endocervical canal and cervical os, producing this type of tissue, ideally as a single piece, which is referred to as a cone. So a cone biopsy or large loop excision of the transformation zone. And you can see here, this is done usually by a hot wire diathermy, which cuts through the tissue and cauterizes as it excises. The advantage of that is that not only will it produce hopefully a single diagnostic sample, which can be used for histology and diagnosis, it also actually produces tissue dieback by 1 or 2 more millimeters beyond the margin of the actual specimen. And that means that if there is incomplete excision on the specimen, it may actually have been treated by the degree of tissue that is affected by the diathermy itself. If that sample is sent for histology, the usual approach is to describe the sample you get in 3 dimensions, serially section it, and you can see here the ectocervix and the canal and the os here, endocervical canal would be here. That is then processed into formalin fixed paraffin embedded blocks and produce histological sections which can be examined down the microscope. Now, obviously, that is only available if you have that infrastructure. Treatment can be offered on a via or villi appearance, but obviously you don't know exactly what you are dealing with under those circumstances. So what is the future potentially for cervical cancer screening? Well, it must lie with greater vaccination rates and coverage. And if that occurs, as in the World Health Organization global eradication policy, then hopefully cervical cancer will become a rare disease, if not a totally preventable disease. With greater vaccination, any screening that is offered, the intervals can be expanded because the negative predictive value of the HPV test allows with great confidence that that woman is highly unlikely to develop a cervical cancer. So I don't think cervical screening will be eradicated for many years to come, but the approach to that and the intervals for it will be. We must hope that new and novel markers will help identify those women with precancerous changes that may develop into cancer rather than regress. And methylation status of the CIN is possibly the most appropriate or the most likely in the foreseeable future. I'm certain that there will be further testing that will be available, whether it's on a histological sample or ideally on a cytological sample or a liquid-based cytology sample, or maybe able to be done at the same time as HPV analysis. That would be the ideal. We must also hope that better treatment options for cervical cancer can be developed itself. Because again, whilst identification of cervical cancer can occur, we must look to improve the clinical treatment of that at all times. So in summary, cervical cancer is a preventable cancer. Screening is very highly effective. The model of screening, as I've indicated, depends very much on so many factors, and there is no right or wrong answer. There is a model that is applicable to your own setting, depending on all the factors I've indicated. But the stress point must be HPV vaccination can dramatically reduce the incidence of cervical precancer and hence cervical cancer. And that must be the aim for the future. Thank you very much for listening.